will have an oral exam with me and another teacher for ID practice. On Friday, I shall send you 20 clinical cases which will be at exam. Very similar of them will be at exam. When you come, you will receive the number of 2 clinical cases. And it will be necessary to answer the questions about the main syndromes and the plan of additional investigations. Each group will have their time. It will be estimated and sent to you on Friday also. We decide that group 76 will start at 9, group 77 at 10:20, group 78 at 12, and all groups meeting will be a quarter to 2 p.m. for solving all the questions or to decide any corrections of the marks. Those who can't come will have additional opportunity, but not with our department. All your marks will be sent to the Department of Propedeutic, and they will put these marks without any changing to examination lists. So you will see these marks in your electronic cabinets, not on Monday, but maybe on Tuesday, the 29th of December. Everything I have said will be in the written form sent to you tomorrow, together with clinical cases, which will be at exam. Do you have any questions about Monday? Colleagues, are you with me? Mm-hmm. The decision of the time for onset was done due to your geographic location, because 76 group, the students are too far from Moscow, so they will start. Okay. If you have no questions, yeah. Absolutely. There is no law not to allow the students to come to the exam, even if the student was absent. There is no law to give a good or excellent mark for attendance during all the classes. Any other questions, colleagues?
Dr. Hello?
To repeat about everything about the exam, yes, 2 cases you will get. 2 cases.
Tomorrow will send for us these cases, yeah?
Yes, tomorrow I
Okay.
shall send them to you.
Okay, thank you.
We shall discuss most of them, and I shall send you. So tomorrow, I shall show you these exam questions, clinical cases. We shall discuss most of them. And I'll answer all your questions about these clinical cases, about some other questions in ID to be ready for exam. So your exam in January, The structure I have discussed with you. There will be one theoretical question and a clinical case. The example I shall show to you also tomorrow. Any other questions, colleagues? No? Okay, 24 students.
So sorry,
yeah.
it will be one case tomorrow and one theoretical question, or two cases and one theoretical question?
You have 2 exams. One
Okay.
exam will be on the 28th of December.
Mhm.
It will be ID practice. There you will have 2 clinical cases. That's all. And
Okay.
a lot of additional questions if it is necessary. If, for example, your answer is not good. In case of if we speak about your exam at the 21st of January, there you will have one theoretical question and one clinical case, and a lot of additional questions, because very often you are sure that it is necessary to say only a syndrome, for example, pneumonia, and nothing else. It is not a correct answer. Be sure that it is necessary to explain your decision, to make full diagnosis, and it is necessary to answer additional question. Answer additional questions because we'd like you to show your knowledges. Okay, 26 colleagues are here. I suppose it's time to start. I shall try to mark your attendance just now. And we shall start with jaundice. So, colleagues, I'm not looking for your attendance. You see, I must do it, but it is up to you. You won't be punished if your attendance is not good. It is your opportunity to attend, not to attend. It's up to you, according to the actual law. Okay, I shall demonstrate you MCQ now. The correct answer is marked with a point. Direct and indirect bilirubin, total bilirubin may be checked at chemical blood test. Direct bilirubin has a synonym as conjugated. And in urine and in the stool, we can find either urabilin or stercobilin. It depends upon the biological source. Increased urabilin makes the color of the urine more dark, first more intensive and then more dark. Intravascular hemolysis is the source of prehepatic jaundice. Indirect bilirubin will be enlarged in blood. In the peripheral blood, we shall see reticulocytosis and indirect bilirubin enlargement. Shunt bilirubinemia, one of the source of it is bone marrow. It is genetic disorder which is named as Gilbert disease. When indirect bilirubin is increased in plasma, sometimes it is not necessary to treat. In case of very intensive appearance, it is necessary to be treated. Jaundice very often is accompanied by skin itching. If it is a prolonged period of appearance, xanthelasms and xanthomas on the skin may be formed. There are some diseases which we shall study on the second step of ID. Their names are primarily biliary sclerosis or fibrosis and cholestasis is typical for it, and sclerotic fibrosis. In the case of primarily biliary sclerosis, we can constatate atresia of small bile ducts. In another case, it will be atresia of large bile ducts. Elastin is bilirubinophilic tissue. That's why we can see a lot of a yellow color on skin, in the eyes. Pancreatitis and damage of pancreatic gland may be associated with steatosis of the pancreas and steatorrhea in the stool. Jaundice, in which direct liver damage is the cause, may be in autoimmune hepatitis, in primarily biliary cholangitis, in alcoholic cirrhosis of the liver. Subhepatic jaundice or jaundice with the cause below liver, not inside liver by itself, is obstruction of holy ducts. And MRI, in this case, magnetic resonance cholangiography, is one of the most diagnostics procedure. In case of jaundice, together with the stony density of liver on palpation, any doctor may suspect a liver neoplastic process, especially metastatic to liver. Alpha-fetoprotein is a good biological blood marker for hepatocellular carcinoma. This is the name of liver cancer, a primary liver cancer. All the disease except rheumatoid arthritis may be the cause of jaundice due to liver damage. And sometimes drug-induced cholestasis with jaundice may be especially due to treatment of, for example, estrogens inside this number of drugs. I would like you to remind the name of this biological oncomarker, alpha-fetoprotein. Please remember it. This question may be at your MCQ. Okay, this test is over. And I would like to present you a presentation. A presentation about jaundice. To revise all necessary points. So as you know, jaundice is not only the change of the skin, but in reality, it is the onset of the syndrome and of the disease. We can see that the skin color and the whiteness of eyes are changed to yellow colors. It is because of high bilirubin level in blood. Feces, dark urine, and itchiness. These are the main signs of jaundice syndrome. Changes of feces and urine. Any questions, colleagues? And itching, maybe or maybe not. They may present or maybe not. It is not necessary for you to know about normal levels of total bilirubin, but we shall see a lot of clinical cases. That's why I demonstrate you the normal positions, either in milligrams. Colleagues, if it is possible, please switch off your microphones. In milligram per deciliter or in millimole per liter, have a look, difference is a real one. And if the level of bilirubin in blood is twice higher than normal, we can see jaundice on the skin. As I have said, bilirubin may be unconjugated or conjugated. The main causes of high unconjugated bilirubin, it is excess breakdown of erythrocytes, large bruises, Gilbert syndrome, thyroid gland problems, and starvation for a long time. Sometimes we can constatate newborn jaundice. It is also due to high level of unconjugated bilirubin. Conjugated high level of bilirubin is typical for liver cirrhosis or severe hepatitis. due to infections which are tropic to liver also, medications and blockage of the bile duct, sorry. All jaundices are divided into 3 gross groups: pre-hepatic, or sometimes it is named as hemolytic because hemolysis is the main source of this type of jaundice. Hepatic or hepatocellular jaundice. The source is damaged parenchymal liver cells, and post-hepatic due to obstruction of the biliary tract. Such infections as malaria because of damage of erythrocytes, sickle cell anemia are the sources of prehepatic jaundice, for example. Viral infections which damage concrete liver cells, alcoholic liver disease, liver cancer, any other, for example, drugs, hepatitis, are the causes of intrahepatic jaundice. Gallstones, pancreatic cancer, bile duct cancer, these are the sources of posthepatic jaundice. This is the biological scheme of formation of bilirubin, stercobilin, and urobilinogen. Next step, you will see this difficult pathogenesis. Now I have marked for you 3 main types of jaundice for you to see that sometimes it may be mixed situation or difficult situation to understand where is it from. This is typical jaundice, and this is typical icterus of yellow, of white part of the eye. As you can see, sometimes it is necessary to ask the patient to look either to the side or upper to verify the yellow color of the eyes. Urine may be changed to the color like cola, and even with a strip, you may verify bilirubin or urobilinogen. Speaking about types of jaundice, we can see that in case of prehepatic jaundice, urine and stool will be of normal color. In case of the hepatic one, they will be dark, I mean urine, and stool will be normal. In case of obstructive, stool will be without black color or brown color. It will be gray or yellow, and we name it echolic, and urine will be dark. This is echolic stool, and this is not very extremely high bilirubin in blood, and urobilin again enlarged in urine. That's why the color still is yellow but intensive. The same may be in case of dehydration. Dark urine due to bilirubin urea. Pale stool we name acholia, and very often it is together with a lot of fat in the stool, which we name steatorrhea. Very often jaundice is associated with itching. Obstruction. It may be gallstone, It may be biliary atresia. It may be problems with pancreatic gland. And here we shall see duodenal part of intestine where both holy duct and the pancreatic duct are opened. So it may be the blockage of pancreatic gland with obstructive problems. To tell the truth, urine color may show us a lot of interesting information. Here we are interested, in this topic of jaundice, we are interested in brown color, which is associated with increased bilirubin. And you may see a lot of other sources of urine color changings. You know that I never read a lot of words. If they are, it means that I wish you to read this presentation, to see it once again without me, and try to learn or to be more familiar to this information. This is the short answers about the changes of colorish of urine and the stool. And laboratory tests that must be done in case of jaundice or suspicion of it. And some details. We have already discussed urine and feces changes. Colleagues, just a minute. I have to answer. If we are interested in bilirubin and its fractions, we can see that it will be concerning total increased in all variants of jaundice. In case of prehepatic unconjugated will be increased. In case of hepatic, it will be it will be also increased. In case of post-hepatic, unconjugated bilirubin will be normal, but conjugated will be increased. Alkaline phosphatase, together with transaminases, alanine and aspartate, who will be normal in prehepatic jaundice. They will be increased in case of hepatic with prevalence of transaminases because liver cells are damaged. In case of post-hepatic, alkaline phosphatase will be highly increased in comparison with LTST. Any patient with jaundice must be done these parameters in blood: bilirubin, albumin, liver transaminases, and alkaline phosphatase and gamma glutamine transpeptidase. Be sure that gamma GT is more specific to biliary obstruction in comparison with alkylate phosphatase. And as for albumin, we are checking the synthetic function of liver. We can divide viral causes and not infective markers of acute liver injury. It is necessary to see all possible and diagnosed hepatitis nowadays from A to E. Don't forget about cytomegalovirus and Epstein-Barr viruses. In case of not infective markers, paracetamol is one of the main killer of liver cells. Ceruloplasmin, the biomarker of heredity-linked disease, which is named as Wilson disease, where excess amount of cuprum is in organism because of deficit of corresponding enzyme for metabolism of cuprum. That's why we check ceruloplasmin. And in case of autoimmune pathology, antinuclear antibodies and immunoglobulins of G subtypes may be interesting for diagnostics. In case of chronic liver injury, the main hepatitis are B and C. All other are not chronicized. And some other abnormalities of not infective etiology may be the source of interest and the source of liver damage. But in details, we shall study it next step, just for you to know that there are some other causes. Speaking about possibility of imaging, we start with ultrasound of abdomen. And if it is necessary, X-ray or its specific modifications such as magnetic resonance, cholangiopancreatography, where we can see holy ducts from liver and the pancreatic ducts from pancreatic gland. These are the main sources which may be obstructed, may be performed. If nothing is understandable, a liver biopsy will solve the problem. Okay, that was about jaundice. And now I would like to repeat the information about gastritis. I have found out that a lot of questions can't be done because this topic, gastritis and enteritis, were not repeated. Let's do it. Also in a short form. So inflammation of the stomach is gastritis. Don't mix with ulcer disease, because gastritis means damage only of epithelium layer, and ulcer damage the epithelium, subepithelium, and even muscles, though the main symptoms may be very similar. As you can see, There are a lot of causes that may result in a gastritis. The main pathology causes are affected the gastric mucosa, and it is real inflammation, all the signs of inflammation morphologically present. The main symptoms are epigastric pain, epigastric, nausea and vomiting. Sometimes it may be anemia, and as complications, ulcers with bleeding. Ulcers and bleeding can't be real symptoms of gastritis. They are considered to be exacerbations of gastritis or complications of gastritis, better to say. The main causes are inflammation due to infective processes and other like autoimmunic. The main diagnostic procedure is upper endoscopy with biopsy of mucus. In classification, two types, acute and chronic. Inflammation and atrophy are the main morphological sciences. I stress your attention at the position that sometimes chronic inflammation of gastric mucosa may lead to epithelial metaplasia, which is named as pre-cancer condition. So the main causes of atrophic gastritis are infections and autoimmune cause. Speaking about common acute gastritis, these are alcohol, just direct damage of gastric mucosa, corticosteroids, NSAIDs, the condition of acute or chronic renal failure, because urea also damage gastric zone. H. pylori is one of the main infections, but have a look. There are some other. Moreover, we are speaking about disbalance between aggressive factors and the factors that defend the gastric mucosa. Risk factors for atrophic and autoimmune gastritis are estimated here, and to understand what autoimmune atrophic gastritis is, you can see some examples. There are some specificities in beta 12 anemia gastritis with atrophic glossitis, diarrhea, and even dementia, because B12 vitamin is responsible for all these zones, intestine, tongue, and brains. That's why not only gastritis, but extra gastrical symptoms you will see. And speaking about infections, there is additional list of possible infections. From other hand, there is another classification which is not very often used nowadays about type E and type B gastritis, but it may be asked at MCQ. In case of A, it is autoimmune, and in case of B, it is H. pylori related. Concerning to anatomic prevalence, A gastritis more often in the body of the stomach, H. pylori in the antral part. So if we give the summary of gastritis, here we are. This is cytomegalovirus. Endoscopy verification is one of the best and may be done for outdoors patients without really a lot of difficulties. But speaking about upper endoscopy, do not forget about mucous biopsy, not only for Helicobacter, but for morphological verification of the inflammation and possible atrophic processes. Speaking about A type of gastritis, which may be associated with pernicious anemia, it is possible to see antibodies to parietal cells, and in this case we shall speak about autoimmune component of gastritis. And some other autoimmune components, as you can see, antibodies to thyroid antigens also. And type B, mostly associated with H. pylori. So endoscopic biopsy, H. pylori detection. If you remember, I have sent you a special presentation about 3 types of tests for H. pylori: blood, mucous, gastric mucous, and even feces. And other laboratory results, without any doubts, we need common blood test, urine test, and common tests of feces. Additionally, in case of autoimmune atopic gastritis, if we even suspect it, it is necessary to see all these parameters. If we compare autoimmune and infection etiology of gastritis, you will see that even the place of damage is different, though in some years it will be pangastritis, so the whole mucus in gastric zone will be inflamed. There are the main mechanism of pathogenesis. Urease production by H. pylori or decreasing of HIPAA of defenders and excess aggressive factors. In autoimmune components, because of vitamin deficits, not only vitamin B, we can see a lot of extra stomach signs, not only epigastric pain. In case of infectious inflammation, neutrophils will be the main K cell of inflammation in comparison with autoimmunic, where lymphocytes will be the main cells of inflammation. Common complications concerning with the impossibility of good vitamin metabolisms and iron metabolism will be result to neoplastic problems, and in case of infections, it will be first of all ulcers formation. Enteritis, inflammation of small intestine in comparison with large intestine, which we name as colitis. The main problems associated with intestine are here. And do not forget about two diseases as Crohn and ulcerative colitis. Previously, 20 years ago, ulcerative colitis was named as unspecific. And if at exam you will speak about unspecific ulcerative colitis, it means that you are looking to the not professional site and reading it. You may imagine the result. Symptoms of enteritis are well known to you, but still we are to revise them. And speaking about duodenitis, we are close to enteritis, and if we try to differ the abdominal pain due to gastritis and enteritis, gastric pain will occur in a short time after food intake, and due to duodenitis, 2-3 hours later, just the time which is necessary for entering of the meal to the zone of duodenal part of intestine. Infections. The main infections are the sources of enteritis. It is typical bad hygiene, one of the professional type of enteritis or due to catastrophe is radiation enteritis. And it may be due to drugs such as ibuprofen, naproxen, or illegal drugs such as cocaine. Also due to autoimmune disease such as Crohn's disease. It is not necessary to give all the peculiarities about Crohn's disease, just name it and indicate that it is the class of autoimmune inflammation. It will be enough for the first step, absolutely enough. So we have done jaundices and gastritis. Colleagues, do you have any questions to me according to these topics? And enteritis, by the way. I suppose no. Am I talking to myself or somebody is here?
We're here,
I see.
Professor.
I see. Some of you are
teacher,
here.
we are here.
Good. Thank you. So, colleagues, and now we shall start with the cases. I can't say they are very interesting because it is difficult from one hand, from other hand, nothing to do. So I can give you a break for 5 minutes, not more, okay? Let's not switch the connection because thanks to Zoom, we can prolong it as long as we need during today and tomorrow, I suppose. I have forgotten. Yes, about the links for your exam at the 28th. Honestly speaking, it is a class time. That's why we shall do it in the Zoom. I shall send you the links. It is not necessary to go to the big blue button. This is an important information because we shall do it like just like class because your exam I just don't know when, maybe the 29th of December. So at the estimated exam time, it is not necessary to come to big blue button. Everything will be done without you concerning ID practical exam.
Professor,
Yes, Farima.
I'm sorry, but what happens if you fail the 28th exam? Like,
Um, you will find yourself at re-exam.
okay, thank you,
Mhm.
Professor.
I suppose it is impossible to fail on Monday. I can't imagine. Only if you have any problems with connection and can't come. In this case, it is necessary to write to WhatsApp. We shall discuss it in 5 minutes. Let's have 5 minutes rest, colleagues. Okay?
Thank you, Professor.
Mm-hmm.
Okay.
Colleagues, let's continue.
Yes, Professor.
Mm-hmm. Let's continue. I would like to say you the following information. So, all departments which are involved in the ID practice have their own exams. Please do not share with clinical cases and the materials concerning to the practical exam to any other groups. Your 3 groups is organized for exam on Monday. It will be in the form we are discussing. Other groups, even from our department, will have another style of exam. Some of them are preparing presentations. Uh, some of them have theoretical questions. It doesn't matter. You have the main correct variant and less nervous one. I can't imagine that some of you can get unsatisfactory mark. I can't imagine it because we worked a lot and we'll have training today and tomorrow, and I suppose everything will be okay. I do not have the goal, as Mr. Beketov also, we do not have the goal to give you bad marks. So, let's continue. Colleagues, you can see clinical cases, very similar. The task is to identify the main syndrome. Please read it. I shall show you on the first clinical case how to answer. So it is an acute situation because it is the sudden onset of pleuritic chest pain and dyspnea. The patient wasn't ill until 3 days ago. The swelling of her left leg, only left leg, she has no risk factors. She is febrile, but with severe dyspnea. With tachycardia, she is normotensive. Accentuated S2 at auscultation, I suppose above aorta or above pulmonary artery. By the way, all these clinical cases are from propedeutic department. Just a minute, colleagues, sorry. I can't see anything to allow anybody to come. Okay. Now I can see it. I have allowed. Mm-hmm. Lung examination and chest radiograph are normal. Not only edema of the left foot, but a lot of pain there. If you meet this example, be sure it is thromboembolism from the leg deep veins to pulmonary arteries. This is the situation why I am glad that we are your exam department, because this material is from the second step, but it is on the first one. We did not have such topic. It is thromboembolism of pulmonary veins. And here you can estimate chest pain syndrome and dyspnea and be ashamed. Why is it so? Because no pneumonia. If you meet such clinical case at exam, it is necessary to provide computed tomography, hemostadiogram, and to detect D-dimer. D-dimer, a blood marker who is responsible for thrombosis. And all other clinical cases are similar to all the topics we have done. Let's discuss. Colleagues, your activity will be fine because it is the possibility to train yourself before Monday exam. So, what do you think is it? Is it a chronic or acute situation? Colleagues, I would like your activity, please.
Acute.
It is an acute situation, you are quite right. What are the main syndromes you can verify here?
Cough,
Maybe have pneumonia.
dyspnea, and chest pain.
Yes, chest pain syndrome and respiratory failure, yes, because dyspnea is a sign. You're quite right. Intoxication. And what is about the lungs? Increased fremitus, bronchial breath
Sorry,
sounds.
doctor, this kid have pneumonia or not?
It is.
Okay, thank you.
But we are speaking about the syndromes.
Mm.
Because these questions will be asked. You will be asked such questions. So increase fremitus and bronchial breath sounds at the right base. This period is without crackles, but it may be. So it is the right lower lobe pneumonia. All the comments you will read by yourself. And now let's just train. Look to this clinical case, please.
Right lower lobe pneumonia.
It is pneumonia. To tell the truth, it is middle lobe, but it is very difficult to estimate by direct examination. X-ray is necessary in this case, direct and right projections, because the patient doesn't have any risk factors like prolonged obstructive bronchitis or bronchitis by itself to perform computed tomography. But she has an acute onset of cough, productive cough with dark-colored sputum, and she is febrile. So we have the local sign of pulmonary induration because of dullness and crackles in the same zone. because of dark colored sputum. These are symptoms of the syndrome of pulmonary induration. And we have, she is febrile, so we have intoxication. This is pneumonia without any doubts, but here it is a middle lobe pneumonia. Here you are. What do you think about this clinical case, colleagues?
Lung abscess. Right. Lung abscess.
You're quite right. Why do you think so?
Because it is.
Once again, please.
Carries. It carries. What I think it carries.
Sorry. It is so because the patient has risk factor for such complication of pneumonia because he has productive putrid foul smelling sputum, very high level of febrile level, and a lot of extrapulmonal zones of inflammation. And we can suspect abscess. It must be identified with the help of which method of investigation? X-ray without any doubts. And CBC will show us high level of white blood cells with their deviation to the left. It means that the number of neutrophils will be very high. Okay, all the comments you will read by yourself. Please, the fifth one. So it is acute situation with sudden onset of sharp one-side chest pain associated with dyspnea, any trauma. The patient really has dyspnea, tendency to lowering of blood pressure, tachycardic.
Nice pneumothorax.
You're quite right. Decreased fremitus, hyperresonance, and diminished breath sounds. Yes, it is pneumothorax, but it must be explained. Why do you think so? Why it is not pneumonia, for example? Because there are no rails, no crackles.
For me, I told because of the hyper sinus, the sounds.
But cyanosis may be also due to infection, due to respiratory failure. Okay. Please, next one. What do you think about this?
I think pleural effusion. I don't know.
I suppose you are quite right. And first of all, I would like to do it like this. And why do you think so? Why do you think it is not in pneumonia, not in pneumothorax?
For me, I think it's a pleural effusion because if it's pneumonia, he will not have pain in the pleuritic chest pain in the wall. I mean,
Mm-hmm. And it is 3-month history. Pneumonia for 3 months. Can it be so? No. Pneumonia is an acute situation. Can a
I know.
pneumothorax?
I mean, lung, it's not sensitive for pain, but the wall of the lung is sensitive for pain. So if we speak about pneumonia, so I don't know, just I
Now
think
you
like
know.
that.
Now you know that it can't be an acute situation. Okay, so it is pleural effusion. How can it be estimated with additional examination? Which investigations are necessary to perform?
For pleural effusion,
Yes.
mm,
By direct examination, you can only suggest it.
yes, maybe X-ray and sputum.
Without any doubts, X-ray. Sputum, if he produces, will be nice. If no sputum and we have pleural effusion, according to its amount, it is necessary. It
We
is,
can. Oh, sorry.
yes, it is necessary to perform what?
Excuse me. And about CT scan, we can use it or not?
You can use it, but there are concrete indications if X-ray is not enough for you, if something is ununderstandable still, you may perform computer tomography, but X-ray will be done in some
Okay.
seconds, even in 2 positions. And for CT, it is necessary some minutes, and it is more expensive. During your practice, you will know that, first of all, it is necessary to follow standard procedure in concrete syndrome or disease. And if you out of this procedure, it is necessary to explain why, or insurance company will give you the opportunity to pay for this investigation. Next time you won't do it. So in this clinical case, common X-ray, nowadays it is very well produces, is absolutely enough. But you are to perform it not only in direct projection, but also in a side one from the damaged side. Okay, let's go on. Yes, by the way, if the amount of liquor is more than 200 milliliters, it is necessary to evacuate this liquor, or if it is pneumothorax, it is necessary to surgically to give the opportunity the lung to come back to its position. I suppose my surgical colleagues have shown you such situations, but we can see here pleural effusion. Okay, here we are with next clinical case. As you remember, I recommended you to see
mitral stenosis.
Yes, to see value disorders and to make a corresponding table. Be sure that at MCQ, it must be just in front of you. And at oral exam, I mean in January also. Here you can see auscultative peculiarities typical to mitral stenosis. You're quite right. Okay, we have done this portion of clinical cases. Here we are with the first clinical case. Please read it. I have marked the main necessary points. Maybe you remember we have seen this clinical case previously. So it is an acute situation above a chronic one. Why above a chronic? Because this lady suffers from chronic alcoholism, but 2 days ago she noticed jaundice. Another symptoms are not corresponding to any other problems, maybe due to exacerbation of her chronic intoxication, but very often they are together with jaundice, because we remember that jaundice may be an inflammation of liver by itself, or
Nephrotic syndrome, maybe?
due to obstruction. Colleagues, I don't ask you about it now. We are discussing. You have no information about her laboratory tests and simultaneously put the answers. No, it is not nephrotic syndrome. If you see ascites, it doesn't matter, because ascites is typical for liver failure also. So she has these symptoms I have marked in yellow, which may indicate inflammation of liver. Which one? This acute above chronic. It doesn't matter just now. The sense of presence of inflammation on the territory of liver is enough to go on. At her physical examination, have a look. She is febrile, tendency to low blood pressure. She is tachycardic. Her consciousness is good, as I can see. Slightly tympanic abdomen. Why is it tympanic? What tympanic sound is about? Is it about liquor or about air?
About
It
air.
is. It is about air, yes. Palpable liver, and it is enlarged together with spleen. So together, liver and splenomegaly. Not only jaundice, but spider nevi. What spider nevi are about? Spider nevi are about varicose changed veins on the upper part of the body. This sign is inside the syndrome of portal hypertension very often. Portal hypertension may be due to liver failure, due to enlarged blood pressure in the vena porta. Have a look. Bilateral tremors of hands is due to liver encephalopathy. So, portal hypertension, suspicion of portal hypertension, of liver encephalopathy, of prolonged chronic process, have a look, bilateral palmar erythema, medical history of chronic alcoholism, are enough to suspect liver failure. And now we have an acute situation because it is inflammation with fever, with jaundice, and we have laboratory results. Inflammation is without any doubts because leukocytes are enlarged. Shift to the left means that it is not only autoimmune enlargement. We are to look for possible infective component, or it is due to necrosis of liver, because inflammation in the liver means necrosis of some spots. It is not the total necrosis. Total necrosis of liver is impossible. It is not connected with life. Hemoglobin is decreased together with hematocrit. It may be due to chronic anemia, and the genesis of this anemia is mixed. Ferrum deficit, vitamin B12 deficit, and the possible bleeding because of portal hypertension. And her MCV is too high, so during last 3 years, she took alcohol and drank a lot, maybe each day, but she is not out of this bad habit. Her biochemical laboratory test gives us enlargement of AST. The upper borderline is not estimated. It may be either 20 or 40. Concerning maybe 40, it is still enlarged more than in 3 times. So it is moderate enlargement. ALT is a little bit enlarged, but believe me, if AST is more than ALT, it is also due to alcoholic etiology very often. Total bilirubin is enlarged, and alkaline phosphatase is enlarged more than in 2 times. What can we see? We can see cytolysis, liver cytolysis syndrome, or we can see cholestatic syndrome. Moreover, prothrombin time is prolonged. It means deficit of prothrombin. And as we remember, prothrombin is a parameter which is responsible for liver synthetic function. So this is liver failure syndrome. During the hospitalization, she demonstrates severe enlargement of leukocytes and bilirubin. And it is during some days, even with treatment. So we can constatate the presence of a lot of syndromes: cytolysis, liver cytolysis, cholestasis, and liver failure. We can suspect the syndrome of portal hypertension. And in this case, it is necessary to perform abdominal ultrasound investigation and to see the diameter of vena porta. If it is enlarged, upper and lower endoscopy must be performed for verification of the status of veins. If they are varicose changed, it may be the source of bleeding. It is necessary to perform stool test, feces for hidden blood, for occult blood, also must be done. So as you can see, no nephrotic syndrome, though it may be associated with liver failure, and in this case, urine test, and not in this case only, but common urine test better to be done. In case of ascites, more often we shall auscultate percussive sound as a dull one. If you percuss your table or something indurated, you will receive such percussive sound. Any questions about this clinical case, colleagues? No, let's go on. Please read it. This is typical situation when some operations, stress factors may realize genetically hidden problem. As you can see, during 45 years, the patient doesn't have any problem with his liver. And now 2 days after operations, he has jaundice. It is pre-hepatic type of jaundice, typical for Gilbert syndrome. The identification of Gilbert syndrome you can read here. Very often we just doesn't touch this problem because it is a mild one, with sometimes of appearance of icterus eyes. For example, in reproductive period, during periods in ladies, and during stress or alcohol excesses, when the dose of alcohol is too much, it may be so. And here we can see the patient's laboratory results. Bilirubin was enlarged severely. 1 milligram per deciliter is upper borderline here in these units. There are no other signs of liver damage. Direct bilirubin is enlarged. Slight enlargement of alkylate phosphatase. Slight enlargement of AST-ALT without prevalence of one of them. Albumin is absolutely normal. Amylase, this is enzyme from pancreatic gland, is also normal. So the only treatment is to be out of any chemical aggression, he can't be without treatment after cardiac operation. So he needs low doses of antiplatelets therapy, sometimes double therapy, no alcohol, and in some days he must be much better. But it happened so. But 4 years following, he returned to emergency with severe epigastric pain, nausea, and vomiting. Even complete blood count was normal. But have a look. The patient starts with the special diet without consultation with his doctor. So it was like gastritis, and 2 months later, again the episode of epigastric pain. In this case, he was febrile, a little bit hypertensive. It may be due to pain syndrome. But have a look. Was it an internal diseases, a therapeutic or a surgical situation? Bowel sounds are markedly decreased. He has enlarged alkylate phosphatase in 3 times, enlarged bilirubin, mildly moderate enlargement of AST-ALT, and signs of inflammation because leukocytes are enlarged. What do you think about the possible cause? Colleagues, this may be very often the situation of post-hepatic obstruction with corresponding inflammation. That's why we can see all signs of inflammation and obstruction. What is inflamed? Liver, without any doubts, and holy ducts. Which one will be estimated with additional investigations, ultrasound, X-ray, and MRI? But bowel sounds means what? How do you name this surgical situation? It is the paresis of bowel. It may be either spastic or mechanic one, but it presents, and common X-ray of abdomen will help us to estimate it. If not, MRI of abdomen will help us. Any questions about this clinical case? No. Okay, let's go on.
Professor,
Yes,
may I ask about
sure.
the test or the exam that we're having on 28th?
Let's interrupt and solve the exam questions. Yes, you can without any doubts. So, what is your
Yes,
question about the
how is it
exam?
going to be? Yeah, how is it going to be? Because I have no idea about it.
You were late. Okay. For everybody who may be late, the exam will be organized for the concrete group in the concrete time. The whole information will be sent to you tomorrow. We shall start today and continue tomorrow the clinical cases you will receive at exam. They won't be new for you. We shall study them, we shall discuss them. Each of you will get 2 clinical cases. The task in each clinical case is to estimate the main syndrome and to give the plan of additional investigations. I ask you not to share with this material to other groups because the groups are in the special blocks, and each block has its own examination material. Especially do not do it with other groups from other departments because they have more difficult tasks, a lot of theoretical questions, though it is practical ID exam. It was the decision of that departments. It will be quiet atmosphere with concrete time to each group. You will have enough time, and at the end of the class, it will be like a class. You will get Zoom links. It is not necessary to go to Big Blue Button. And we shall discuss if anybody doesn't understand the mark according to the exam. For example, I give you 5 and you are against this mark. We shall discuss why is it 5, not another mark. Colleagues, it's not a joke, but I am against stresses during the exam. I have the single goal to give you good marks and to say you goodbye. Everybody is tired. The situation is extremely severe in the most countries. It is necessary to be very careful. It is necessary to work, to study. But it is not. It doesn't matter that we are only to have a stress. It's enough sources of stress, except exam. So each of you will have a dialogue with the teacher about your decisions. That's why I try you to talk to me now and tomorrow. It is a repetition, it is a training before the exam. The same will be in January at your oral part of the ID exam. The same, you will get a clinical case and an exam question. All material for January exam you have already got. And it is an advice not to share with this material with the students from other departments because they have another material. They have twice more exam topics. There are a lot of peculiarities in their clinical cases for exam because a lot of them are from the second step of ID. I don't know why is it so. But they are educated by another department. Maybe they have discussed these topics. So no sources of stress for you. Just it is necessary to come. And to
Thank you,
do it in
Professor.
time. To do it in time.
Yeah, sorry about that.
Understanding that, understanding that there may be a lot of peculiarities of your tendency. I understand it perfectly. Connections with internet, some other business, well, your bad feeling, anything. You have additional time on Monday during the class to come and to have your mark. Everything is for you, everything. for you to be in a convenient style. Nobody will be punished. You see, we are not at school. And even at school, I don't know why punishment is still present. It is not necessary. Everybody will get the mark which is responsible to the knowledges, to the ability to answer. It is not necessary to jump out from the trousers, to do something else. Just train yourself. It will be enough. Let's go on. Yes, you can see.
Professor, excuse me.
Yeah.
Previous case, the liver damage, the inflammation, is it because
Yes.
of was caused by the diet or
So
what is
the first episode, it was because of his Gilbert syndrome.
Yes, I'm talking about the second, the inflammation.
The second episode, it was because of diet. Yes, protein-rich diet damaged his liver because it is necessary to metabolize this excess amount of protein. And it was very difficult. So it was together with pancreatic gland epigastric pain. Have a look. It was epigastric pain. Liver by itself doesn't have pain receptors. They are only in the liver capsule. Inside the liver parenchyma, the same inside the pulmonary tissue, you won't find pain receptors, or we can't live. But in pleura, in liver capsule, there are a lot of pain receptors. But localization of the pain in case of liver damage is to the right. The same as for gallbladder. Here we can see pancreatitis together with gastritis. And liver is also damaged, but not so severe and with restoration. But again and again, it was with cholestatic syndrome. And at the third episode, after something else, I suppose he kept another diet, another cholestatic problem. And here we need amylase and ultrasound to see maybe it is a gallbladder stones formation or just such severe inflammation of holy ducts. At the second step of ID, we shall come to the logical point. And I have stopped here just to show you that recurrent cholestasis may be, but there must be under some, together with some causes. Okay, clinical case number 3, please. Just analyzing this yellow marked place, what do you think? Which type of jaundice or which types of jaundice does this lady have?
Intrahepatic
or post-hepatic?
post-hepatic?
Yes, 2 variants, not prehepatic. Yes, you are quite right. So non-steroid drugs in high doses, though she started H protectors, they protect mucus of gastric zones. So we can see scleral icterus, no other signs of chronic liver damage, normal blood count, good coagulation factors. I remind to you that there are prothrombin, fibrinogen, all of them are created, synthesized in the liver. So they are parameters of liver synthetic function. If they are normal, there is no liver failure. Slight enlargement of alkaline phosphatase, of GGT, enlargement of total bilirubin and direct one. So we were right, suspecting not prehepatic jaundice. Severe enlargement of transaminases, they are more than in 18 times enlarged. Total protein is good. And serum albumin is a little bit decreased. 4 years ago, liver function was good. Ultrasonic examination. You can see the lesion of pancreatic gland. They suspect that it is a lymphatic node. No ascites, no signs of inflamed gallbladder. And because no concrete answers were given with the help of ultrasonic examination, computed tomography, either MRI may be done. Here it was computed tomography with and without intravenous contrast. Mild periportal edema. What does it mean, periportal? Around portal tracts in the liver. Still, gallbladder was changed with signs of inflammation. Periholistic fluid means inflammation. So problems in pancreas. Autoimmune components and viruses, hepatitis viruses, were negative. Heredity diseases were negative, but serum ferritin was elevated. And the conclusion was as drug, toxin, induced hepatitis. So the conclusion is we can see from one hand drug-induced hepatitis, from other hand some peculiarities in pancreatic gland. It may be due to such liver damage. And the same was the reaction from gallbladder, though the walls of gallbladder were a little bit indurated, so it is chronic cholecystitis without any stones. just secondary to the inflammation of liver. Colleagues, any questions to this clinical case? No? The goal was to show you the source of jaundice. It was intrahepatic one.
I would like to ask, why is serum ferritin is elevated?
It was like an acute reaction to the inflammation due to liver damage. Sometimes it is like a marker of acute inflammation. Sometimes, not always.
So it was like resulted from the hemolysis of some RBCs or something?
Yes, because drug-induced damage may also damage erythrocytes, but we catch it at the level of intra-liver damage. If no treatment, if she continue take NSAIDs, it will be another mechanism additionally pre-hepatic damage with hemolysis. You are quite right.
Thank you.
All these clinical cases are from the second step, but reduced for you. So this one, please. Enlargement of thyroid gland. And let's see the results of laboratory tests. They are started with thyroid stimulating hormone and thyroid hormones. See the references. So what do you think? Which kind of jaundice does this patient have? Both total and direct bilirubins are enlarged. No cholestasis, just alkylate phosphatase and GGT are normal. And enlargement of liver enzymes. With their,
Hepatocellular jaundice?
you're quite right. It is liver jaundice due to damage of liver. Why is it so? Because of thyroid gland disease. It is autoimmune disorder and autoantibodies attack liver by themselves. We can see the clinic of hyperthyroidism, and liver damage. Different diseases with equal cause, with connection between them, not the equal cause, but the connection between them. Because thyroid gland disease damaged liver. This is the scan of thyroid gland. As ultrasonic specialists said, say it is hot gland, inflamed. And it is necessary to exclude other possible causes of liver disease. And here we can revise them. We have discussed these are infective components with well-known hepatitis, Epstein-Barr virus, cytomegalovirus with their antibodies. Why both G and M antibodies are marked? Because the infective process may be either chronic or acute or exacerbated. Here are also nuclear antibodies corresponding to other autoimmune diseases, heredity diseases, ceruloplasmin and hemochromatosis, and other infections, and ultrasound of the abdomen. Please remember this investigation, which is named as MRI cholangiopancreatic. You may be asked about it at ID exam and at surgical exam. As you remember, pancreatic ducts and the biliary ducts are opened to duodenal zone, very close to each other. And cardiac problems also may be so. Here we can see normal fraction. Colleagues, let's have 5 minutes interruption. So colleagues, let's continue. Let's continue. As you can see, it is the situation when thyroid gland damage may be associated with hepatic dysfunction, with formation of jaundice, without pre-existing liver disease. Okay, that is all in this block. And now we shall start the clinical cases, very similar to those that will be on Monday. Let's start. I invite you to answer these questions. it is necessary not only to name the syndrome, but to explain why do you think so, and to make the plan of necessary investigations. So
I think
maybe
it's obstructive
yes.
jaundice.
Please, why do you think so? Answer this question. Why do you think so? Why is it obstructive jaundice?
Because of left hypochondrial and epigastric pain. This is the place where the gallbladder is, and after food intake, because like after food intake there is secretion for bile juice, and if he feels pain at the secretion of bile juice, it means that it's obstructed. That's my
Okay,
conclusion.
okay, David. First of all, it is good that you decide to answer, but tell me please, where do you think where do you see jaundice here?
Oh, sorry, I thought we were continuing
But
on this
really, your logic is absolutely correct. If jaundice is estimated here, you are quite right, yes. But the jaundice is not estimated here, and have a look. Abdominal palpation reveal tenderness in the left part of epigastric area. So just forget for a minute about jaundice and try to do it once again. It is a chronic situation with an acute above chronic situation. Why is it so? Because the patient has the medical history of alcohol abuse. Yes? And left hypochondrial and epigastric pain. Tell me, please, which organs are projected with pains here to this zone, which is indicated?
Spleen.
It is too high to the spleen.
Stomach.
It is partly stomach, duodenal zone, and pancreatic zone. These three organs. But the epigastric pain usually appeared 2 hours after food intake. It is more typical to duodenal and pancreatic involvement, though to stomach. Stomach more earlier, less than 1 hour. At night time, it is also typical for duodenal localization of damage. Irradiation to the back in belt-like pattern. It is typical for pancreatic gland. And damage of external pancreatic activity may be described by diarrhea and losing of 8 kilograms for last 2 years. It is chronic process with chronic intoxication. Nothing is said about liver because it doesn't give us any pain syndrome. And he comes to the doctor only because of pain. According to these clarifications, what would you suspect? Which syndrome or syndromes? It may be duodenitis or gastroduodenitis and pancreatitis. Once again, why is it so? It is so because onset of the pain syndrome 2 hours after food intake and at night time during the starvation. With irradiation like belt, typical to pancreatic gland. Nighttime epigastric pain more typical to duodenitis. Left localization is also more typical for duodenitis and epigastritis. Oh, pancreatitis, sorry. So we can suspect gastroduodenitis or only duodenitis and pancreatitis. Understanding that it is so, or which investigations are necessary? Please, colleagues, what do you think? Which investigations are necessary? If it is gastroduodenitis, what will help us?
Endoscopy.
Yes, upper endoscopy. If you answer only endoscopy, you will be asked which one. In this case, upper endoscopy. Is it enough? What is about other instrumental tests, investigations?
X-ray maybe.
X-ray. X-ray of what?
Of the abdomen.
Abdominal. What is it for?
For investigating if there is some masses, maybe.
Common X-ray won't
Or,
give you enough information. I suppose my surgical colleagues taught you that common X-ray of abdomen is fulfilled in case of bowel paresis, when you do not auscultate bowel murmurs, bowel sounds, or they are so loud that it's better to investigate. And the corresponding X-ray symptom of paretic intestine and bowel will be presented. Do you know about it? I shall try to find during the next break. I shall try to find such X-rays. This is the only purpose for X-ray in emergency. Speaking about computer tomography, it may be, but we need contrast and we need some time to get creatinine result in blood. Without it, we can't perform any contrast investigations. But easier, or we can perform ultrasound of abdominal area. And if we are lucky, if the patient is not obese and not excess gas in the abdominal cavity, we can see pancreatic gland. We can see pancreatic gland, and it will be enough if there are any severe abnormalities. Severe masses we can also see with the help of ultrasound, the gross masses. So ultrasound, and it's better to exclude or to identify ascites, excess gas in abdominal cavity. This will be enough. And then laboratory investigations. What do we need here concerning duodenitis and pancreatitis? Yes, we have forgotten to say that during upper endoscopy, it is good to perform biopsy of mucose for two purposes: Helicobacter pylori investigations and morphological verification of the type of sputum damage. As we have discussed, it may be any type of gastritis also, and duodenal biopsy if it is necessary. What laboratory investigations here will be suitable? What do you think? complete blood count. Without any doubts, it will show us the inflammation, and we can suspect or exclude bleeding. Which parameters will show us inflammation? Leukocytes, erythrocyte sedimentation rate. Which parameters will show us possible bleeding or its absence? Hematocrit and erythrocytes. Yes, so CBC. If we speak about possible pancreatitis, which investigation will show us inflammation of pancreatic gland? Which enzyme is it necessary to check in the blood? It is amylase or lipase in urine. And this will be enough. If more intensive investigations are necessary, please don't forget about MRI or CT with contrast for verification of Holy ducts for liver and pancreatic ducts and gallbladder together. All this zone will be checked with the help of the contrast. You will be shown the walls of the ducts, all ducts, and possible interruptions, atresia, stones, any other formations, tumors, and so on. Okay, colleagues, any questions about this case? No? Okay, let's go on. Case number 2, please. So who is ready to answer the questions?
Maybe duodenal ulcer?
It is duodenal problems, but why do you think it is ulcer? Why not duodenitis? We can't estimate either it is duodenitis or duodenal ulcer, yes? But the logic is correct. Is it an acute situation or acute or exacerbation of a chronic one? What do you think?
I think it's chronic.
You're quite right. It is chronic because we have the history of 2 years of such episodes with relapse in autumn and vernal time. It is typical for exacerbations of stomach and duodenal problems, itises or ulcers, either gastritis and duodenitis or peptic ulcer diseases. First question, why is it duodenal zone, not gastric zone? Because of the location. Is it estimated? No, it is not estimated because it is 2 hours after food intake. You may suspect it is gastroduodenitis, and nobody will punish you. It will be a correct answer because it is very difficult to separate these 2 organs. What investigations are necessary?
Endoscopy.
Upper endoscopy with biopsy. Don't forget to add it or you will be asked about it. So gastric zone, duodenal zone must be expected. Yes. What else?
Ultrasound
Ultrasound of which zone?
of the epigastric zone.
Abdominal ultrasound, what will you verify here?
Any abnormalities in the like in the wall of the duodenum, maybe.
Maybe, but it must be extra high class ultrasound. More often, it is enough to, well, images are enough from endoscopy. It will, first of all, answer to the question about liver sizes, spleen sizes, about vena porta and the absence of excess amount of gas and the absence of liquor in abdominal cavities. Okay, laboratory. Yes, and what?
Blood test. We will
Yes.
check for the count of leukocytes, because if it's duodenitis, it means it's inflammation, and inflammation attacks
Good.
leukocytes.
With left deviation possible without it. Yes, and we shall notice the level of hematocrit and hemoglobin to be sure that the patient doesn't have bleeding. Yes, the same as for a cold blood stool test, especially if endoscopy verifies ulcer damage, which is more suitable with bleeding than only duodenitis. Okay, it is good. By the way, 2 hours after food intake and relief by intake of antacids, typical both for gastritis and duodenitis. But 2 hours after food intake, it is more to duodenitis. Good.
Can we make
Yes.
a check for the gastric juice in the blood?
If it is necessary. Nowadays, it is estimated that it is not of high level of diagnostic sense.
Professor,
Yes.
can
Yes.
we add urea breath tests for the investigation?
Without any doubts, but if you perform endoscopy, you will take all necessary material for Helicobacter test, because urea test may be limited because of antacids intake, if you remember. Yes, proton pump blockators and antacids are contraindicated if you'd like to perform the tests for verification of Helicobacter with exhalated gas or in feces. And they are not contraindicated if you will test the material which was taken with the help of biopsy. And the last case in this block, please. There are two syndromes here. Look attentively at hemodynamics parameters. It is an acute situation without any doubts. So, colleagues, it's again duodenal zone damage, but The damage is more to peptic ulcer disease. Why? We can see decreasing of blood pressure. It is typical for shock with tachycardia and corresponding dyspnea. It is because of cardiovascular problems. So it is necessary to perform simultaneously upper endoscopy and take complete blood count to see the level of hemoglobin and hematocrit. Very often, 99 percentages that it is gastroenterological bleeding. And because of epigastric pain after food intake in 2.5 hours, it is duodenal zone. So it is an emergency situation, and we can't divide it to surgical and therapeutic one. Sure, it is more close to surgical. Endoscopy will be of diagnostic sense from one hand, and of treating. We can treat with the help of endoscopic procedure the bleeding from the ulcer, and then intravenous corresponding therapy for treating of the ulcer of duodenal zone. Is it clear? Once again, why am I ready to suspect gastroenterological bleeding? Because of low level of blood pressure. All other parameters are because of decreasing of blood pressure. These are compensative mechanisms. Questions?
Okay.
No.
And
Yes.
why after having pain at nighttime?
At night time, for duodenal ulcers, it is typical to have, so to say, starvation pains. Aggressive factors are more aggressive without food. When food have gone away from the zone of inflammation, they are more aggressive. That's why after food intake, when food comes to the zone of duodenal tube, and then when the tube is empty. It is
So
typical
it's
for...
not related with circadian rhythm?
Yes, it is because of vagus activation also. Yes.
Okay, thank you.
So 5 minutes of resting, I shall try to find you X-ray pictures. So colleagues, let's come back. I shall demonstrate you the problems with intestine and bowel. So if there is abdominal pain, especially in the zone around umbilicalis zone, if you auscultate absence of bowel sounds or they are not normally loud, common direct X-ray of the abdomen may be performed, and you may see such levels of liquor, air fluid levels like this. And you can see the zones of distended small and large intestine. It's better visualized here. Air and liquor. Air is dark, liquor is slight gray, light color. The main X-ray sign of obstruction of bowel is cups. We can see this white zone and dark gray or even black zone. This is air, this is fluid. As our surgical colleagues taught you, it may be two types of blockage. It may be mechanical or paralytic. Mechanic or not mechanic, or spastic. Here we can see. This is the lying position. That's why air is at such level. This is the patient's neck. And these are typical X-ray sciences. Auscultation is the main propedeutic direct exam procedure to verify problems with digestive tract, to suspect its paralymph. And here you can see the main symptoms. And the source where you can go and revise this topic just to refresh it in your memory. So when you answer about X-ray investigation in abdomen, just common X-ray, direct one, remember that you can see here the condition of damaged intestine or bowel, or both of them, with such X-ray phenomena. In Russia, we name them cups. Fluid and air, air and fluid. Mm-hmm. Mm-hmm. Okay, so colleagues, do you need any prolonged break before we shall start with exam clinical cases? Do you? Colleagues, are you with me? Something is written. Yes, you need. Okay. How much time do you need? 20 minutes? Is 20 minutes okay? I can give you half of an hour as you like.
Yes, it's okay.
Half
20
of an
minutes is
hour?
fine.
20
No,
minutes.
20 minutes, 20 minutes.
20 minutes.
Yeah, 20.
Okay. So we shall start at 12:10 by Moscow time. Okay? 12:10
Yes.
by Moscow time. See you. It's a pity that not everybody will be involved in the process. So these are the clinical cases you will see at exam. on Monday. We decided to send them today. If you have any questions, we shall ask them, we shall answer them tomorrow. I suppose we will be able to solve not less than half of them, maybe about this, but tomorrow we'll have another opportunity to do it. So let's start. The task is indicated, and 2 standard questions are here. Yes, what would you like to ask?
Can you send for us the cases for today for
Yes,
example?
we shall do it today. I shall
Okay,
send
thank you.
to your leaders and they will resend to you
Okay,
without
you.
any doubts.
Thank you.
Once again, please don't share with this material to other groups, only groups 78, 77, 76 are here with these clinical cases, because they will have other. It doesn't, it is not necessary to do. The first clinical case, please. I suppose we have done it. Yes, no?
Pneumonia, maybe?
Yes, you may suspect pneumonia. Why do you think so? Which are the main syndromes here?
Sudden onset of chest pain and shortness of breath.
These are
Okay.
sciences. These are sciences. We're
Yes,
speaking
science.
about syndromes. Colleagues, I remind you what syndrome is in comparison with sign. It is a group of sciences. Syndrome is a group of sciences which are connected pathogenetically. We shall discuss it once again tomorrow. But please now be sure that all you have mentioned, these are sciences. You are quite right, but these are sciences. Try to connect them to a syndrome. It is heart failure and intoxication. Yes? You can suspect syndrome
Heart
of...
fail because of what?
sorry, respiratory failure. Respiratory failure.
Respiratory fail. Okay, thank you.
Yes. You can suspect syndrome of pulmonary induration. Yes, you can suspect it. Okay. So what investigations are necessary? Just one by one, and what are they for? Please try.
X-ray for the chest.
Which one? Common X-ray, indirect projection, yes? And if there are any abnormalities from one or both sides, it is necessary to perform sides projection, one or both. Good. What would you like to verify at X-ray? Which syndrome? The syndrome of pulmonary induration, yes? So the focus is of pneumonia. What else? Colleagues, what other investigations are necessary to perform here?
ECG. I think.
ECG. It will be nice to have ECG, Okay, because we shall treat the patient, we need ECG. What else? If we are speaking about pneumonia, just switch on the protocol of pneumonia investigation. What is it? X-ray, then CBC. We are interested in leukocytes, deviation to the left, ESR level. What is the main parameter, biological parameter for pneumonia? Because it may be a bronchitis also. How can we differ them without X-ray? C-reactive protein is a marker for pneumonia of
I
any type.
That is thickening of the wall.
Once again, what?
The difference between bronchitis and and pneumonia, thickening of the wall.
Yes, you will see it, but we are speaking about a variety of necessary investigations. For example, X-ray won't show you any pulmonary induration. It may be in case of viral pneumonia. What shall you do? And it will be signs of chronic bronchitis at X-ray with induration of bronchial wall. So you need C-reactive protein for verifying that it is pneumonia. Colleagues, just standard procedure for each syndrome. Write it down. We have done it for a lot of time. It is in each presentation. Just write it down. Pneumonia, X-ray, CBC, C-reactive protein. And give the details. What would you see at complete blood count, for example? You will be asked about it. Okay, let's go on. Case number 2. You have an opportunity to train. Imagine it is an exam. And try, please.
It's maybe pneumonia too.
You're quite right. And the same, yes, the same procedure for investigation. Yes, yes.
Doctor,
But yes,
in the first case, you told us we have a respiratory fail and pulmonary induration.
Yeah.
Okay, thank you.
And you can see it here without any doubts. You can.
So what is
please? Yes.
Doctor,
just a minute. I shall answer to the phone.
Okay.
Слушаю. What was your question?
Signs of pulmonary induration. What is it?
What are the signs of pulmonary induration in this clinical case? Because in this one, we can only suspect them. We have no results of direct exam. Here we can see the results of direct examination. And it is increased phrematous and bronchial breath in the right base. And there are crackles in this area. Crackles.
Okay.
These are the main signs of pulmonary induration, together with the syndrome of intoxication and respiratory failure. Why respiratory failure? Because of dyspnea. Why dyspnea? Because the number of breaths movements is more than 18. And you can imagine that each pneumonia is accompanied with mild or more severe respiratory failure. It can't be without. Absolutely can't. So the same standard procedures, the same plan of investigations must be done. If it is estimated that the right lung is damaged, let's provide right side X-ray, a direct one and right side.
And we can use CPC2, yes? CPC2, yes?
Complete blood count or
Yep.
computed tomography.
Complete blood count.
Complete blood count will be enriched leukocytes with left deviation in typical situation, ESR enlargement, maybe elements of anemia. That's all.
Okay, thank you.
Colleagues, any questions? We shall, we have enough time to train. Okay, let's go on. So please, the third clinical case. Do you have any
Pneumonia.
class? The third one, I suppose it's more close to bronchitis. Colleagues, do you have any other classes today?
No.
No?
Mhm.
Because honestly speaking, our class is over according to the timetable. But I decided to prolong it, and if anybody wants, it is possible to be away of our class, and nobody will be punished. Don't worry. But I suppose that it's better to do maybe 10 clinical cases for you to understand what is necessary to do further with other. Okay? Okay? Okay. So, why it is not a pneumonia? Have a look.
Maybe because of wheezing.
For
and
10
bronchitis.
years, just remember, pneumonia always is acute situation. It is an acute disease. Here we have 10 years disease with productive cough. It is bronchitis. Cough occurs during the whole day with sputum. And several times a year, she has exacerbations because sputum becomes purulent. And she requires antibiotics therapy. Yes, it is exacerbation. She doesn't smoke. Maybe there are some occupational harm factors. And at examination, we can auscultate wheezes and rhonchi, which are diffused. So inflammation like pneumonia of all fields of pulmonary tissue, we can't imagine. It is impossible. It is unconnected with life. So it is bronchitis without exacerbation because it is not declared that she has any fever, any green or red color of sputum. So it is a common bronchitis, chronic one, without exacerbation. What shall we do in investigations? First of all, we are interested whether the patient has respiratory failure. 10 years may formate respiratory failure. That's why we need in direct examination the number of breath movements. Then we are interested in her vital parameters, blood pressure, heart rate, because we ought to know about them. Maybe he is a hypertensive patient. She may be. And directly to chronic bronchitis, it is also necessary to perform X-ray, common X-ray, spirogram to see the obstructive components, because wheezes are very often associated with bronchial obstructive syndrome. We can suspect it here. And sputum test. We know about sputum test. It must be done to see the key elements of her chronic inflammation. It may be neutrophils if the main cause are bacterial inflammation. It may be allergic inflammation. In this case, it will be eosinophils. In case of neutrophils excess, it is necessary to perform cultural test to try to see the microorganism responsible for this chronic inflammation. And chemical test to verify the absence or the presence of atypical cells, which may be due to cancer, bronchial cancer. In case of appearance of atypical cells, computed tomography of the chest must be done. And this is the whole investigation in case of chronic bronchitis. Complete blood count I have mentioned, or maybe not. So any questions about this clinical case? No. The next, please. We have done it. We have done it, and it is not necessary to repeat, I suppose. Oh, no, we haven't do it. Sorry. Let's do it. So, colleagues, maybe somebody wants to give comments.
Lung abscess?
Why do you think so?
I don't know.
Now, let's
Smelling
analyze
the sputum productive of putrid, so it says. And the crackles, the dull percussion, it's just the abscess, lung abscess. And the elevation of blood urea may be damage to from alcohol.
Urea in this case is together with crackles. Crackles, first of all. Crackles are formated in alveolus, demonstrate as pneumonia. And you're quite right. Putrid fluid smelling sputum may be associated with pulmonary abscess, very common in alcoholic persons with pneumonia as an exacerbation or as a complication of pneumonia. Better to say a complication of pneumonia. Moreover, we have the situation of bad dental hygiene. And the patient also has respiratory failure. And urea is not given here only due to his liver status. If we look at CURB scale, CURB, C, consciousness, nothing is mentioned, so let it be normal, 0. Blood pressure, normal. But respiratory rate is more than 32, and urea is really enlarged in 3 times. So 2 points this patient has. What does it mean? That the duration of the pneumonia is moderate or severe, and he must hospitalized. Moreover, he has concomitant condition. Next step, we shall teach you that delirium is very often in such situations. That's why he must be under hospitalized observation. At this step, it is necessary to calculate CURB scale to show your knowledges and to say that it is not mild duration of pneumonia. First of all, because of respiratory failure, and of this level, 32 is rather severe dyspnea, and intoxication. Blood level of urea indicates the level of intoxication. Is that clear? What investigations are necessary? X-ray, first of all, because we are to see where the abscess is. It may be done as CT for better visualization. Common blood count, chest, chemical blood test to see liver function and liver inflammation because of his peculiarities in medical history, and maybe abdominal ultrasound to see the presence of portal hypertension of ascites or to exclude these conditions. Is it clear? And what are the main signs of intoxicative syndrome here? Fever, chills, urea. These are. Good. Let's discuss the 5th one. So, what would you suspect here?
Bronchial asthma.
You see, you may suspect bronchial asthma because of wheezing.
Yes, and because of he used accessory muscles.
Yes, you are quite right. At least if you say about acute bronchitis or exacerbation of chronic, you won't be wrong, because inside bronchial asthma, we have bronchitis. And
Pneumonia.
And no pneumonia is here because we can't see the local abnormality. We can see it's diffuse. What is about 40 breaths per minute? How would you identify it? As which syndrome? And using of additional muscles. This is respiratory failure, colleagues. It is respiratory failure. And another syndrome is arterial hypertension. So what is necessary to be done? X-ray, common one, or according to the age and the possible prolonged situation, computed tomography without contrasting. CBC, especially for leukocytes and eosinophils. Eosinophils must be done both in percentages and absolute amount. Sputum test, common one, and cultural. Also chemical sputum test, or sometimes it is named as cytological. Cytological is better. What else? Do we need, for example, spirometry here? No. How can you imagine spirometry at such dyspnea? No, we do not need. Saturation may be done by pulse oximeter. And ECG, hypertension, and maybe echocardiography to see the fraction of ejection and to see the right side of the heart. Because I suspect not only respiratory failure, but heart failure here, maybe. This is the plan of investigation. Any questions? Okay, what is here? Clinical case number 6, please. It is an emergency, acute situation.
Bronchial asthma?
Or obstructive bronchitis, acute obstructive bronchitis. Saturation must be measured by pulse oximeter. And X-ray, chest X-ray, direct projection. CBC. And C-reactive protein, the same as for previous clinical case. That will be enough here. As you can see, we can't perform spirogram. It will be done after recovery from the acute situation. Any questions, colleagues?
No, thank you.
Okay, the 7th, please.
Pneumothorax pneumonia?
Well, I suppose it is obstructive bronchitis because of the lung examination.
I'm not really certain.
With mild respiratory failure. And it is very typical to heavy smokers. So according to these diagnoses or number of syndromes, the plan of investigation will be spirometry, chest X-ray. Because of prolonged smoking history, computed tomography will be better to verify the peculiarities of emphysema. Spirogram with bronchodilatator test. If sputum production presents sputum test, both common and culture. Complete blood count, C-reactive protein. Spirogram, I have said. Questions? No, okay. Here we are. Clinical case number 8. So how to calculate the deficit of the pulse? 110 minus 85. It is 25 beatings per minute. It is a real pulse deficit, a significant one. So the main syndrome is arrhythmia. What must be done? First of all, ECG, computed tomography for the purpose to exclude the thromboembolism of pulmonary arteries. Natriuretic peptide, edema of legs, we can suspect heart failure. And complete blood count to exclude inflammation. Any questions, colleagues? Okay. 2 more clinical cases and we shall finish. Here we are, please. Have a look at the blood pressure level. Tendency to be low. ECG signs of arrhythmia. Moreover, we can estimate it. It is atrial fibrillation, irregular ventricle complexes, and absence of P waves. And edema of feet, low blood pressure, tachycardia. It is heart failure. So echocardiography must be done. Pro-BNP or BNP in blood as a marker of heart failure. Complete blood count and biochemical blood test. In biochemical blood test, common parameters of function of renal of kidneys and electrolytes like potassium. And the last one, please. What are the main syndromes here? Without any doubts, we can speak about arterial hypertension, and we can suspect heart failure. In this case, it is necessary to perform ECG, echocardiography, complete blood count, chemical blood count to verify the function of kidneys, urinary test for albumin in urine and full urinary test, and fundoscopy. 3 target organs must be verified. Daily monitoring of blood pressure will help us to estimate the degree, because now we can speak about the 3rd degree of arterial hypertension. Okay, colleagues, let's finish today's class. During this hour, I shall send you these clinical cases. And tomorrow we shall continue to discuss these clinical cases. Do you have any questions to me? No? Okay, thank you for your attention and your attendance. See you tomorrow. We shall start at 9:30 tomorrow. Thank you. Goodbye.
Thank you, Professor.
Thank you.
Goodbye.
Thank you.